So just a few logistical things. We will hold all questions until the end, but if you'd like to put them into the chat box before then, we'll save the questions and begin to queue them up for the speakers. I also want to let you guys know that the call is being recorded. So if you have any objections, now is the time to disconnect. We will begin recording of the meeting now. Okay, perfect. All right, so I will pass the mic to our co-chairs, Jen Chapman and Jeffrey Campbell, to open the meeting.
Thank you, Ivory, and welcome to everybody joining us from all over the U.S. today. Thank you for joining the Advancing Health Equity webinar. Sorry, getting closer to the mic. Is that better?
Yep.
Oh, will this work? Yeah. Okay. Is this better?
Yes.
All right. Thank you all for joining us from all over the U.S. today for the Advancing Health Equity in HIV webinar with UCHAPS. My name is Jen Chapman, and I am the community co-chair of UCHAPS. I'm joined by your newly elected community co-chair, Jeffrey Campbell, who's, I don't believe, has audio that works right now. Oh, he does. Okay. Jeffrey?
I do. Good morning or good afternoon, wherever you are. I'm Jeffrey Campbell. I'm the newly elected government co-chair for UCHAPS. I'm glad to be here with you today. This is, I think, a great opportunity for us as UCHAPS doing these webinars to engage more individuals from across the nation. So looking forward to having a great time today as well as tomorrow afternoon. So welcome. Kevin?
Oh, wait, I'm sorry. I can't hear you. Can you turn your audio on? Turn your sound back up.
My sound not muted. Okay. Hello, everyone. Can you hear me now? Better. All right, great. Thanks, Derek. So good afternoon, everyone, or good morning, depending on where you are. This is Jeffrey Campbell. I am the newly elected government co-chair for the Urban Coalition for HIV and AIDS Prevention Services. Excited about today and tomorrow's webinar because using this webinar style gives us an opportunity to reach and engage more individuals from across the nation. So looking forward to a great meeting. I think Kevin's up next.
Hello, everyone. If you can just give me a quick time check or at least respond in the text box if you can hear my voice. If you can hear my voice, clap once. If you can hear my voice, clap twice. If you can hear my voice, clap 3 times. Thank you. Thank you, Stephanie. Okay, so I am very excited to join each of you in this virtual space, as well as having some different individuals in the office, and to talk about our health equity and advancing health equity in HIV. Today's conversation will help UCHAPS complete its urban health agenda. As many of you may remember, in 2002, UCHAPS released the first urban agenda on preventing AIDS in America. This report, which you can find on our website, really described the epidemic that was happening in our 6 jurisdictions at the time that were directly funded from the CDC, including Chicago, Philadelphia, New York City, Houston, Los Angeles, and San Francisco. And as someone who was an outsider to UCHAPS at the time, I found a lot of worth in having the UCHAPS urban agenda. It allowed me in Massachusetts to think about the work that I wanted to do in urban communities to help prevent the spread of HIV. In fact, the urban agenda that was produced in 2002 had 3 goals. And one goal was to describe the multiple factors that interact to pose continual challenges to HIV prevention. 2, the urban agenda wanted to define HIV prevention challenges that must be faced by elected and public officials, our health and social service providers, individuals, families, communities, all in the hopes of ending the spread of HIV. Thirdly, we wanted to set forth new policy directions that would address the many social, economic, and health disparities that were facing our urban communities. And we identified 31 areas for advocacy and support. And when we look back on those 31 points, we know that there's still work to do, but there are also some ways that we have got ahead of the epidemic and the disease, but still more work to do. We are excited now 16 years later to come up with our next urban health agenda to really think through those additional areas to get to the end of the epidemic. The urban health agenda that's set forth by UCHAPS will be our guiding star as we really work with our urban jurisdictions as well as others to prevent the spread of HIV. So I want to thank each of you because your voice, your contributions will all be needed for shaping the urban health agenda. We have on today's call someone that will be working with us to draft and write that urban health agenda based on the collection of materials over the years. That person will also be reaching out to some of you to conduct some one-on-one interviews to clarify some of the information that we've been discussing over the past couple of years, as well as during today's conversation. And lastly, if you have additional information that you would like to add or have considered for the urban agenda, I want to encourage you to email Ivory Howard, who is our CDC project director. I think she's waving her hand somewhere, or she's clapping, if you can hear her clapping. So thank you very much to each of you. We look forward to today's conversation. And before we actually go into the next portion of today's meeting, I definitely would like to thank our partners for today's meeting, including the Centers for Disease Control. The CDC has been a great partner of UCHAPS and has worked in partnership with a lot of our work. We really take seriously our relationship with our federal and national partners, and some of them have signed in today. So we'll be doing more work together, and just want to say thank you for their support and contribution to today's meeting. Thank you.
Okay, so I know that some of you are new to UCHAPS, so that we will take just a moment to play the video.
UCHAPS is a national organization founded on the principle that communities and health departments can work together to really help address the HIV epidemic. Over the last 30 years, there's been a concerted effort to identify the resources, the policies that are really needed to address HIV and AIDS. UCHAPS has been a part of that work by working with our health departments, working with the CDC, as well as working with community to help educate as well as help advocate for the necessary resources.
There doesn't exist another national opportunity for community and government voice collectively together, striving to educate and inform and respond to HIV.
There are social issues, health issues, discrimination that our communities deal with on a daily basis. So prevention in an urban community needs to address all of those. UCHAPS has been a leader in understanding the social determinants of health and in bringing people together to learn from each other, share successes, discuss challenges, bring problems to each other.
UCHAPS has had a remarkable history. Through our platform of collaboration, we've been able to drive resources, identify the right policies, as well as the right practices to help drive many of our successes around HIV.
We're at this amazing place right now in the epidemic where people really believe in the idea of ending AIDS in the United States. And I think UCHAPS provides a great opportunity for some of the hardest hit areas in the country to be leaders in that effort of ending AIDS in the United States once and for all.
Even though we're a small staff, we have a wealth of experience, especially through our membership.
At minimum, every 4 years, the world around us changes, and we have to be innovative, and we have to remain passionate and figure out how to move forward in a world that literally can change overnight.
You know, not only are the folks at the table staff of governmental agencies or CEOs, but they're also, in some cases, they're people who've been living with HIV for several decades.
The community perspective is the real deal. It's the people who know what's happening in the community.
We talk big ideas at UCHAPS, and when I go back to my community, we make it happen. I get to sit and learn from all of the other public health experts who are at the table. And I get to see what successes, and I get inspired by the success that I see that they're sharing. And I get ideas about things that we could implement either at my own organization or to bring back to my community planning group. I think UCHAPS has a great role to play, not just around HIV and AIDS, but also around other health disparities that we see in our cities. It is a group of probably some of the smartest and most dedicated people working around public health that I've ever met.
Resources are finite, and oftentimes we have to lean on each other to learn how to do more with less, but how to even do better in challenging times.
My hope for the organization is that we will publish and share more about what we know is working.
As citizens of the United States, but also as global citizens, we have a right and a responsibility to be concerned about our neighbors, to be concerned about what's happening, and to be able to offer something that people can use. That's our value. That's how we build and sustain our work over time. And I know that will drive us to successes to come.
Okay. All right. So let's move on. We'll begin with our project officer, June Mayfield.
Good afternoon, Aubrey. Can you hear me?
June, your line is open. You may have to unmute yourself on the screen or...
Good afternoon. Can you hear me now?
Yes, we can hear you.
Awesome. Welcome, everyone, and I'm going to reiterate good afternoon and good morning to others. I'm so glad that everyone was able to join this webinar on advancing health equity in HIV. I think this is a very critical an important time to address this topic and to actually add it to your urban agenda as you're starting to update your due process in your new document. I am very excited for the organization to actually bring about some new documentation and some new road mapping that has not been done for quite a while with the last urban agenda. And so I just want to bring greetings from CDC and from Janet Cleveland, and to say that I am very excited to hear what everyone has to present today and to actually see it come to fruition in the new urban agenda document. I think that this will be a roadmap for some of the jurisdictions that are not directly funded, but are definitely impacted. So I want to definitely just be, I'm excited. I think that I'm speechless at this point. This is new technology that UCHAPS is using, and I think that this is excellent because at this point in time, it can be placed on the website, and other people can utilize this tool, this information from all of our SMEs and all of our peers that are speaking today on this webinar. So I just wanted to say thank you. And thank you for everyone's service in the jurisdictions. And thank you for your dedication to HIV prevention, education, and have a good day. Thank you.
So good afternoon. Can everyone hear me? Can I get a yes? Thank you so much, Marcus. So, and I guess, Ivory, I will advance my own slides. I'll bring them up and do that. Can I get a yes? Okay.
Hi, Lamont.
Hi, Ivory. Hi.
How are you? I'm going to pull your slides up, and you're free to begin whenever you're ready.
Great. I think I may be able to request control of the slides, or will you advance them? You let me know what works well for you.
Okay, UCHAPS.
All right, Lamont, go ahead.
All right. So again, good afternoon, everyone. My name is Lamont Scales. I'm with the Centers for Disease Control and Prevention, and I work in our Division of HIV/AIDS Prevention's Office of Health Equity. Just want to say thank you to Ivory and Kevin for organizing a great meeting. I love the technology. You know, we get hiccups every now and then, but it's great that we can see each other face to face, and hopefully we'll have a conversation. Kevin and Ivory have asked me to kind of frame today's conversation around health equity. So I'll do that while talking about our Office of Health Equity, and we'll also share some of the activities that our division is implementing to achieve health equity. All right, next slide, please. So I wanted to first share our division strategic plan, some of the goals, which many of you are very familiar. One is to increase the knowledge of individuals' HIV status. One of the primary activities we feel works really well for that is HIV testing. Next is to prevent new HIV infections. And we know with the new advances in PrEP, we want to make sure that anyone who is HIV negative has, and if they want to, have access to PrEP. Next, we want to reduce HIV transmission. And with the science and the data, we know that if a person who's living with HIV is virally suppressed, it's virtually impossible for them to transmit the virus. So that is one of our goals, to ensure that individuals are virally suppressed. And then finally, we want to make sure that we can rapidly detect and interrupt active HIV transmission. So really looking at clusters and intervening pretty quickly. What you will notice to the far left, what guides all of our activities here at the Division of HIV/AIDS Prevention is that we want to reduce HIV-related health disparities. So that really means targeting populations that are disproportionately affected by HIV, whether that's African Americans, Hispanic or Latinos, gay and bisexual men, people who inject drugs. Those are the populations that we need to work with. So we make sure that we are targeting the right individuals. Next slide, please. So I wanted to share with you the mission of our office. Our office was established back in 2010. It's the Office of Health Equity. You can say our mission is to identify scientifically effective strategies to reduce disparities in rates of HIV among groups that are more or less advantaged socially and economically. We're led by our Associate Director for Health Equity, which is Dr. Donna Hubbard McCree. She's our lead behavior scientist. So she does the bulk of the writing and working directly with our senior leaders in the division. She also supervises our postdoctoral fellows. So these are postdocs who come to CDC for a few years to work here with some of our researchers and gives them a great opportunities to do the work with communities of color. We do have 2 vacant positions that are open. Hopefully we can fill those at some point, but we have a behavior scientist position and then a public health analyst position that historically works with African Americans and incarcerated populations. We have 1 person who is dedicated to working with Hispanic and Latino activities, and that's Mr. Emilio Herman. Many of you may know him already. And then you have me, a short guy who's working on activities for gay and bisexual men. If you have not worked with our office before, or you're not familiar with our office, I kind of sum it up like the role of our activity in 3 different areas. One really is we set the program and science agenda for our division. So that means we get to work with all of our 10 branches and ensure that they are looking at the data, looking at the science when it talks about how to achieve health equity. So we work with our communication branch, we work with our programmatic branch, we work for our epi branch, a whole bunch of branches we get to work with and their partners. Next, our center and our division each have goals around health equity. So what we do is we report and we monitor those activities. And if we feel like there are changes that need to be made, we're able to give some input. Finally, we're responsible for representation and for partnership. So we want to make sure if anyone's having a conversation about HIV that we're at the table. If we're working with local partners, other national partners, or federal partners, we want to be at the table and leverage those resources. So if that means having conversations with the Department of Education or the Department of Labor, then we want to be at the table to leverage those resources. One of the other notable things that we did sometime last year is we convened a meeting, and some of you were a part of that meeting. We thank you for your time. It was the HIV in the South meeting, where we heard from partners from within the South to talk about some of the challenges that they were experiencing and ways that we should be doing things differently. So we're taking that information and implementing that in some of our current work and moving forward. So that's our office. I'll answer questions about our office if you have those later. You can go to the next slide. Yep, so charting our course for health equity. What I did want to use to kind of frame our conversation is a common definition that we use here at CDC. And we get this definition from the Braveman article, where it says, when all people have the opportunity to attain their full health potential and no one is disadvantaged from achieving this potential because of their social position or other socially determined circumstance. So when you have conversations with different people, there are different approaches that they might have for achieving health equity. There's a thought that if you look at the image, that if we just treat everyone equally, that will achieve health equity. And as you can see in the picture, that really is not the case. I think when we want to achieve health equity, we have to consider a few things. We have to consider the types of resources and the amount of resources that we provide for a particular population. If you can see the short guy on the far right, for certain populations, it may mean doubling our resources so that we can achieve health equity. For other groups of people, it may mean a box is not going to work. You might need a ladder for them to achieve health equity. So we have to be okay with that. I think we also have to consider when we're setting targets, what's the right target that we have to set for different groups. If you look at certain people's strategic plans or their goal may be for 80% of all people with HIV to be virally suppressed. That's a good goal. However, you're still going to see gaps and disparities. And even for some groups, you may see the gap even widen. So if we have to allocate more resources to a particular population, so for example, would be for all African Americans who are living with HIV, we want to make sure that 80% of them achieve viral suppression. Now, for other races, maybe for Caucasian individuals, it might be about 60% when you set your targets. That'll help narrow the disparity gap. So I think those are the types of conversations that we have to have. Then also looking at different modules that might be able to estimate the amount of resources and what targets to set so that we can narrow the disparity in the gap. Next slide. So I just did want to share a few of our activities that we have here at CDC that are helping us achieve health equity. Many of you are familiar with our Partnership for Care, which works with health departments and community health centers, helping them to better collaborate. So making sure patients are receiving wraparound services. And that's a demonstration project I think many of you are familiar with. All of you, I think, are well aware of our integrative surveillance and prevention program, which really kind of helps our health departments merge between surveillance and program activity. So it's a united front to make sure that health departments are ensured that they can find individuals who are living with HIV quicker and implement some prevention services. I talked about our Communities of Colors postdoctoral fellowship program, which brings in postdocs who are of color and doing research on individuals who are of color. Next slide. 3 other projects that we have. One is our comprehensive project for MSM of color, which really addresses the barriers or the social determinants of health that prevent Black gay men from accessing care and prevention services. So if that's employment, transportation, they have been given the resources and the charge to come up with demonstration projects so that we can learn from them. And they're going pretty well so far. In the middle, we have our PrEP and our Data to Care project focused on MSM of color and transgender people, looking at what's working well for PrEP. Again, they were given money to make sure that they can come up with modules that I think we can use. And then finally, our CBO program for, I think we funded about 30 different community-based organizations to work with gay men of color, particularly young gay men of color and young transgender persons of color around prevention and care services. Next slide. Just want to acknowledge Dr. Donna Hubbard-McCree for assisting me with this presentation. And thank you for the invitation to start a dialogue on ways that we can achieve health equity, and I hope that I can be of support to anyone. Thank you.
Thank you so much, Lamont. And thank you again, June, for your words. I'd like to introduce now Peter McLeod, who will be moderating our next panel of speakers. Peter is the community co-chair for our Public Policy Committee.
Thank you, Jennifer. We're fortunate today to have 3 expert panelists here to discuss the changing landscape of healthcare, mounting concerns in the HIV community, and ways that health departments and local HIV organizations can commit to health equity and social justice. Sean Bland is a senior associate at the O'Neill Institute and works on HIV law and policy initiatives. He holds a Juris Doctor from Georgetown University Law Center and a Bachelor of Arts in Psychology from German Studies from Yale University. Jennifer Driver is the State Policy Director at the Sexuality Information and Education Council of the United States. As the State Policy Director, Jennifer is responsible for overseeing the state and territories' policy analysis, planning and managing research, and state policy development across the organization. And finally, Devin Barrington Ward is president of Impulse Group DC. Impulse Group DC has been able to bridge divides existing within the community and show they are as passionate about standing up to injustice as they are for advocating for sexual health. Today, we'll begin with Sean Bland. Sean, your line is open.
Hi, good afternoon. I hope everyone can hear me. Again, my name is Sean Bland, and I'm a senior associate at the O'Neill Institute for National and Global Health Law, and that's based in Washington, D.C. at Georgetown Law Center. I was asked to talk about the importance of health equity and some strategies or ways for us to kind of support health equity in our community. So I'm going to just start by saying that when we talk about equity, we are talking about justice. So health equity is a principle that motivates focusing on and eliminating health disparities and shifting the conversation about HIV and other disparities from being solely about health care matters to being matters of social justice. And this means attuning ourselves to issues of race, but also to sex, gender identity, sexual orientation, class, geography, immigration status, housing status, disability status, etc. So I'm going to talk briefly about how we can work to advance health equity in relation to some specific communities most impacted by HIV. So I'm going to start by talking about the transgender community. So transgender people, particularly transgender people of color, are disproportionately affected by HIV. I think we know those stats. Transgender women of color have the highest rate of HIV infections of any subpopulation in the US. And around half of transgender men with diagnosed HIV are Black. So not only are they dealing with disparities, by gender identity, but also we see racial disparities as well. So I want to just talk about some possible steps that we can be taking to advance health equity for transgender women and men. So first, we need to greatly expand trans competency of the healthcare workforce. And that's including providing cultural sensitivity training and also racial justice training at all levels of health departments and also health centers. We also need to hire trans people of color in our agencies and our organizations, including at leadership positions. So I think we're all attuned to like trying to be more inclusive, but that inclusion, you know, isn't just at the bottom of the organizations, it's looking all the way up to the top. We also need to be thinking about data and how we can capture sexual orientation and gender identity information in a more standardized way in our medical records in order to generate high quality trans-specific data to inform all of our efforts. So forming our efforts in terms of national guidance, but also at the local level. In addition, we need to integrate HIV treatment and prevention with comprehensive healthcare, and so that includes gender-affirming care and other services such as housing services, employment and vocational services, and also legal services. And as a lawyer, I'm going to talk a little bit more about kind of the role that medical legal partnerships can play for a variety of communities to advance social justice. In addition, we need to develop health interventions and also marketing, so our communications to different communities. We need to be specifically speaking to the transgender community and particularly transgender people of color. I think often our interventions are developed with gay and bisexual men in mind, and then we adapt those interventions to fit trans women of color, or hopefully increasingly more of a focus on trans men. That may not be effective, and it may not speak or resonate with individuals in the trans community. It's also important to conduct scientific research to better understand public health activities for both trans women of color and trans men of color. And specifically, we have very, very little data on HIV among trans men. And so we need to better understand that population and their HIV prevention needs. So I'm going to move on to talk about health equity among immigrants and also people who are undocumented. So immigration policies, I hope this is something that we can all agree to. It's very evident. It impacts health, and it impacts the ability to provide adequate health care to communities most in need. So it's first important that we recognize the diversity of immigrant voices that are out there. When we think about, for instance, Latinos and immigration, Latinos are not a monolithic group. There are Mexicans, but there are also Puerto Ricans, Cubans, El Salvadorans, and many other groups. There are also Black immigrants, Middle Eastern immigrants, and others. We also need to make sure that we're elevating the voices of immigrants and undocumented people and their families, and be sure to emphasize their stories. I think in particular at the local level at this time, the prospect of kind of positive immigration legislation, I mean, we're still fighting for that and pursuing that at the national level, but I think there's a real opportunity to have a real immediate impact at the local level. We also need to just be very conscious of making immigrants and their families feel welcome in all of our different organizations and spaces. And to do that, we need to have signage and brochures at our clinics, at our community-based organizations, just to welcome individuals, to show that we are providing services and meeting and are attuned to their particular needs. And we also need to be doing affirmative training for providers and all of our staff on issues that might be affecting immigrants or people who are undocumented. And to the extent possible, embedding legal or immigration services in our hospitals and our health centers or community-based organizations is important. And so when I talk about that, I really am thinking about just the model of a medical legal partnership. That's something that has existed for a long time, and they have been existing, but at this particular time, we need to be scaling up those interventions. And where it's not possible to do a medical legal partnership in-house, we need to be adapting policies to make sure that we can triage people. So either triage them to external legal or immigration services, but also to mental health and other support services. In many cases, if we're not able to find an immigration solution, and with the current status of DACA the way it is, there may not be an immigration solution that you can provide, but it is important to make sure that we're attuned to and taking care of the kind of holistic needs of individuals and communities. And I think that's a way in which we can start to be supporting health equity. So in continuing this discussion, I think it's also, I want to kind of turn to talking about gay and bisexual men of color in particular. And there's a variety of things that we can do. I think probably one of the first things is to really just follow the science that's out there. As we continue to see kind of disparities in both HIV treatment and prevention, particularly around PrEP for gay and bisexual men of color, so particularly Black and Latino gay and bisexual men, it's important to remember that we have some research out there. So we have HPTN, so HIV Prevention Trials Network 073, which has demonstrated that we can have high PrEP uptake, for instance, among Black, gay, and bisexual men when we utilize client-centered care coordination. And so what we need now is to actually be implementing and scaling up that evidence-based intervention in the real world. And, you know, I think we're seeing it piecemeal, but I think this is something that we can really be doing in each of our jurisdictions and nationally, consciously realizing we have this intervention that works and making the investments to actually scale it up. We also need to recognize that, you know, communities of color have often mistrust of the healthcare system, and we need to find ways to counter that mistrust and to improve access to healthcare. And again, one way to do that, I think, is through kind of a client-centered approach where we're, you know, focusing on, you know, the needs of the priority population, and also making sure that, you know, we're providing services in a culturally competent way and with, you know, providers and with health navigators who are from those communities. Additionally, it's important to strengthen health literacy because I think many people, including people of color and particularly gay and bisexual men, you know, aren't really accustomed to going to the doctor. I recall just a few weeks ago, I had a conversation with a friend of mine who's a fellow lawyer, who's, you know, in his early 30s, white, obviously very educated, and he kind of just asked me, you know, how do I go about finding a primary care provider? And I educated him and gave him some, you know, advice in terms of how to go about doing that. But it just made me think that if someone like that, who has, you know, much privilege and education and probably lots of resources, at the age of 30, doesn't quite know how to even find a health provider, let alone go and engage in healthcare. We have a lot of work and kind of education to do to kind of make sure that people are at a point where they can, you know, access HIV treatment and prevention as well as broader healthcare. Additionally, as we're seeing, you know, the greatest increases in new HIV infections among Latino, gay, and bisexual men, we need to do significant more to tailor our HIV treatment and our prevention efforts to support this population. And this includes providing, you know, culturally responsive and also linguistically appropriate interventions. And then lastly, I think it's really important, and this is something that I see and I'm heartened by every day, and I like to hope that I'm part of becoming a next, you know, generation of leadership, but continuing to bolster leadership among Black and Latino communities, particularly among gay and bisexual men. I'm going to talk a little bit more briefly because I'm sure I'm reaching my time, but talking about what we can be doing also for women of color. I have a few kind of ideas there in terms of what we need to be doing to kind of tailor particularly our kind of prevention messages to better reach Black women as well as other women of color. And this includes changing the ways in which we talk about risk and think about risk perception and making sure that our messages match and are going to be effective when talking to this cohort of people, so women, as opposed to gay and bisexual men or trans individuals. We also need to integrate HIV and with sexual and reproductive health services. All of us collectively need to be engaged in support of sexual and reproductive health organizations, which really are in the fight of their life right now. And many of the battles that they're facing, particularly around kind of conscious and religious objections to providing abortion or other family planning services are also, I mean, they're affecting our communities, but they also have the potential in the future to be affecting, even in a greater way than they already are, access to HIV care, whether that be things like PrEP or, you know, transgender healthcare. In addition, we need to be educating our providers on the importance of things like PrEP for women and for women of color in particular, and find ways to increase PrEP delivery, particularly in settings where women are. So whether it be family planning centers or other places, we need to be making sure that we're targeting our efforts and really meeting the needs of this population. Additionally, we need to adapt models for trauma-informed primary care. I mean, this is something that applies not just to women, but to all of the communities I've talked about so far, and many more, as well as to address unique needs that women face around just their own life circumstances, whether it be juggling family, work, health, and other responsibilities, and kind of the impact that that can have on HIV treatment and prevention. So I'm nearing the end of my time, and I'd be happy, of course, to talk during the discussion about some specific work that we're doing here at the O'Neill Institute. But I did want to mention a few other things. I didn't really speak about adolescents or a lot of other populations, but particularly adolescent health equity. We actually have some work that we're doing right now focused on supporting access to PrEP among young people, with a focus on barriers such as the ability to consent to healthcare without parental consent, things like confidentiality and cost. I would also be remiss if I didn't mention the need to protect our major governmental health legislation and programs, so the Affordable Care Act, Medicaid, and Ryan White. Efforts to put in like work requirements and drug testing for programs, and also just to undermine the ACA are very real threats to health equity. We all need to continue to push to support those programs, as well as to push for Medicaid expansion in states that haven't taken up that option. And many of those states are in the South, where we're seeing, the majority of new HIV infections. And on a separate note, there is a lot of support for the Ryan White HIV/AIDS program. And while I don't think many in our community, would see that as being something we need to be seeking reauthorization at this point in time, we may not have a choice in that matter, and so we need to be prepared to deal with conversations around reauthorization of Ryan White. Finally, I can't talk about health equity without talking about stigma. And so and when I'm thinking about that, I'm not talking about just HIV stigma, but also stigma around being LGBT, Black or Latino, poor or undocumented. And in the context of the current opioid crisis, it's particularly important that we work to destigmatize drug use. And so I'd be happy to kind of have some more conversations around that and what are some best practices that we should be supporting to deal with the opioid crisis. Again, thank you for allowing me to speak today. And please let me know if you have any questions.
Thanks, Sean. Next up is Jennifer Driver from CISCUS, who has CISCUS is UCHAPS' new next door neighbor. Jennifer?
Can you hear me?
Yes.
Okay, perfect. Thank you so much. My name is Jennifer Driver. I'm the State Policy Director with CISCUS. CISCUS is the Sexuality Information and Education Council of the U.S. And so first off, I just want to thank UCHAPS and CDC for actually allowing us to join this conversation and really putting young people a part of this conversation when we talk about health equity. Often when we have conversations around HIV or health equity, young people are left out of the conversation. So I thank my last colleague or panelist for bringing up adolescents as it relates to health equity. I also really enjoy what he said about health equity as justice. That's something that CISCUS really affirms. Is, our work is really around sexuality is a fundamental right, and it's a part of being who we are, one that's worthy and dignity and respect. And when we talk about sexuality education and our rights and justice, we do bring a youth lens, and so we're working to ensure that young people have all of the access to information. And so when we talk about health equities and some of the needs for young people, one of the things that we advocate for is comprehensive sexuality education across the country. And for those of you who are familiar, comprehensive sexuality education is education that starts in kindergarten and continues all the way through 12th grade, and it's developmental and age appropriate, and presents medically accurate information that builds on knowledge and skills that were taught at previous stage. One of the biggest challenges for young people is that lack of information, and part of in keeping health equity as it relates to young people is protecting the federal funding that has been put out and reducing harmful access-only education or programming that's currently being invested. So one of the things that we do at CISCUS is map out policies that advance or restrict the goal of achieving health equity as it pertains to young people in states and communities. In addition, we work to work with providers to put out PrEP toolkits, so how to talk about PrEP to young people, what is the parental consent conversation, what's the confidentiality, because we know that those are barriers when it comes to young people accessing PrEP. The other thing that we talk about when folks are putting together programming and models to improve health equity is keeping in mind transportation and cost to services, keeping things in mind such as classism and ableism, and health literacy as it relates to young people. I was in a healthcare clinic that was working to reduce HIV among youth in care, and we had gone to the health clinic, and some of the words were just in medical terms, doctor's language. So young people were really feeling uncomfortable, not accepted in these settings. And so really making sure that when we're providing these services to young people, that it's in a way that is accessible and meets the young people where they are. The last thing that we also talk about when we look at health equity among young people, changing the way that we talk about sexual and reproductive health, making sure that we're coming from a rights-based approach. I love what the last gentleman said about stigma and shame. Often when we talk about sex and sexuality, young people are left out of those conversations and aren't able to make those rights and decisions for themselves. And we like to bring this kind of rights-based approach when we talk about sex and sexuality. When we're looking at the young people that we serve, we also break down the population. So not only thinking of young people as a holistic group, but breaking down and referring to addressing the needs of LGBTQ young people, youth of color, immigrant young people, especially in this age of DACA and deportations, the access that young people, young immigrant youth have to healthcare services is really important. And so as I mentioned, talking about policy, because that's really what SECAS focuses on, the policies in states and communities, we have two resources that we work with states and communities on. The first one is our state profiles, which highlight health factors among young people across the country. And so it's state by state maps out the trends of young people, the federal funding, the access to services to young people in those states, and whether or not there's comprehensive sexuality education funding. Just the flag, there's not. Up to this date, the federal government has not allocated $1 to comprehensive sex ed services, which actually increases healthcare services for young people in states and communities. The other thing that we put out is our legislative report, and we track this daily, the policies that will advance or restrict services to young people in states and communities. And so in summarizing this stuff a bit, sorry, I'm dealing with pneumonia and I'm starting to feel the effects of it a little bit. Speaking of health, the overall part that we were trying to get across today was really incorporating young people as part of the conversation, making sure that when we're thinking of health equity, we're thinking of the rights and the justices that young people deserve and really should have access to. And so I applaud this group for actually considering young people as part of the conversation when we're talking about health equity. Thank you.
Thank you, Jennifer. Our next presenter is Devin Barrington Ward, President of Impulse Group DC. Devin?
Good afternoon, everyone. And I'm sure there are people in other areas of the country where it's not afternoon, so good morning. My name is Devin Barrington Ward, and I want to first thank UCHAPS and Kevin and Kenya for inviting me to participate in this important discussion around health equity and what that means for the various organizations and agencies that you all represent. I want to start the conversation with a quotation that I love and I really think kind of frames and sums up the work that we should be doing. And he is beloved here in Washington, D.C., and I'm not talking about the man at 1600, but I am talking about Frederick Douglass, who once stated that those who profess to favor freedom yet appreciate agitation are those who want the crops without the plowing of the ground. They want the rain without the thunder and lightning. They want the ocean without the awful roar of its many waters. Power concedes nothing without a demand. It never has and it never will. I think that quotation is appropriate because when we're talking about equity, I think that we have to be talking about how power equaling a demand actually equals, to me, tangible health equity outcomes, right? So many of you all work in organizations or agencies at the community level that community perceive have a certain level of power, and you all do. And so when the power that you all have meets the demand of the community, that is when you really are able to see the most desirable health outcomes and health equity and racial equity. Because if you're talking about health equity and you're not talking about racial equity, then you're not talking about health equity. And so I think conversation can be broken down in a few ways. One, the first way I would like to break it down is that health equity, looking at it from an internal perspective. So what you all can be doing at your organizations or agencies internally to promote racial and health equity, right? And so I think, one, it starts with the staff. We know that there are, we go to conferences and we talk to our colleagues, particularly some of those who are getting started in the field or who may have been in the field for a little while, and they talk about the environment of the agencies that they work at. That is very important, because if you cannot start with if equity doesn't exist within the institution and amongst its employees, if it's not a standard, if it's not a cultural norm in the environments that you work in, then it's going to be impossible for you to achieve equity with the clients in the community that you're serving. So what are some examples of that? One, I think organizations, if you are a large organization, multi-million-dollar organization, there's probably a good chance that there may be some racial equity issues that may exist within your organization. That doesn't necessarily mean that your organization is inherently racist. That doesn't mean that the people who are leading the organization are inherently racist. But because we live in a society where racial equity issues exist across the board, it is very naive to think that these issues don't exist within your own organizations. So you should be talking to your staff. You should be exploring opportunities around developing racial equity teams, to look at your policies and look at funding, to look at how staffing decisions are made, and to incorporate racial equity in those decisions, because that does promote health equity, particularly amongst your staff. If your staff is taken care of, then there's a better opportunity for them to be able to take care of the community and clients that you all are striving to serve. Another example of that is, I was working at a very large organization here in Washington, D.C. that serves a majority of African-American population as it pertains to their clients. And if you have an $85 million budget, there's probably a strong chance that you're spending lots of money out with vendors, whether that be IT systems, caterers, people who are coming to do the cleaning. There are a variety of services that you all have to get as a consumer, as you all's agencies and as departments and things of that nature. And so is one of the things that we know promotes good health outcomes is financial security. So does the vendors that you are working with, does it represent the population pool that you're serving? Trust me, 6 degrees of separation, particularly in this town, is less. I guarantee you there's a client of yours that has someone in their immediate circle that may offer a service that you may need. And that is a different conversation when you're coming to community and saying, when the community knows that you all are not just serving the community, but you all are also spending money in the community that you're serving. That is very important, because so often, there's a garbage truck outside, and I thought it was the end of the world, y'all. I'm sorry. Everybody in the room was like, hey, what's going on? It did sound like it was coming in the building. So that's just one example internally of how you can be promoting health equity. I really think, and I use that example because that's something that we personally champion at Impulse Group DC. We have a lot of different costs that we have to shoulder. Events, catering, print material, and we try to make sure that the majority of the money that we spend stays in the community that we serve. And that really does give us a different level of a relationship that we have with the community when we're able to say that we spend dollars in the community that we serve. The other thing that I would mention is making sure that internally that employees are empowered and that there is a sense of, I have a trajectory here, that people care about what my my value as a person here. They care about whether or not this position is going to set me up for the things that I would like to do within the next 5 or 10 years in my career. That's important because oftentimes, particularly people of color that are working in health institutions and in the HIV space, talk about feeling pigeonholed, talk about the concerns around, you know, I have 5 degrees and I'm concerned that I'm only going to be able to be a community health worker for the entirety of my career. And so I think it's really important that folks feel like they have a trajectory and that they feel like they have value within their institution. And thus, externally, they can be more equitable with the clients that they're serving. Now, from the external perspective on health equity and racial equity, it's inherently rooted in public policy issues. And so if you aren't engaging in some form of advocacy and policy, then again, in my opinion, I don't know if you're really engaging in the best form of health equity or racial equity for the communities that you're serving. So I know many folks are like, okay, well, I'm a nonprofit or I'm a government agency. And when you say advocacy policy, it scares me. I want to debunk a few rumors. One, there's a common myth that 501c3 organizations cannot lobby. That is not true. There are parameters around how you can lobby and how you engage in advocacy work and policy work. But the idea that you cannot engage in it at all is simply just not true. And you should be engaging in it because you all know better than anybody else the issues that your clients are dealing with and how those things translate from public policy that may have had the right intentions but didn't translate right on the ground. You all are able to speak to it from a place of authority that no one else can speak to it from. So that's one. Also, I would check in with your organization if you aren't necessarily in a leadership position. Let's say you're not the executive director or a senior level position where you can make that decision, then talk with your executive director. And they may not know that they can engage in some lobbying and policy and advocacy activities, but it's so important because when these issues don't happen in a silo, HIV, high rates of HIV, the same communities that are dealing with high rates of diabetes, high rates of hypertension, high rates of mass incarceration, high rates of homelessness. These are all issues that are rooted in racial equity, health equity, but also one of the ways that we can alleviate these issues is through engaging in legislative advocacy, lobbying, policy, and things of that nature. I think another thing that's really important is to understand for the government folks, I understand it's very clear you all cannot lobby, but that doesn't mean that you cannot engage legislative stakeholders in the work that you all are doing. And this goes for 501c3 organizations as well. If you haven't invited the local elected official to your organization to see the work that you all are doing in community, you really should be doing that because that's how you build champions. That's how people become vested in your issues without you even having to ask. Sometimes just the invitation and people can put 2 and 2 together. The other thing that I think for the government organizations that are really important, particularly at the local level and at the state level, hold policy briefings, engage your legislators, let them know the work that your organization is doing, and bring community in so that the community can make the policy and advocacy asks that you may not be able to make as the administrator over your program. So if you know that, for example, a great example of this is around HACWA. We know that the formulary change has cut funding in a few cities, Washington, D.C. and Atlanta being one of the examples of that. This is a great opportunity to do a briefing and just brief the elected officials in your area about the work that the health department does as it pertains to HIV prevention and how these structural and social determinants of health issues impact the work and what you are able to do right now, where the challenge is as far as where the gaps are concerned, and then community. When you bring community stakeholders in the room, they can make the ask that you may be barred from making as a government employee. And then on the flip side of that, as a government employee, when community is asking for you to be a resource to them, be a resource to them. That's health equity. That's racial equity. They may not know the ins and outs of your program, but they may know that on the ground, it's not making the best impact. And you may know that it's not making the best impact either. So that's an opportunity for you all to work in collaboration where you provide the information and they go and make the ask. policymakers. So that's a few things as far as my perspective on race and health equity work that should be being done as we try and end the HIV epidemic and other health disparities within our communities.
Very good. Okay, thanks. Thanks to our three presenters for taking the time to share your work with us today. We'd like to open it up for some questions now from the audience.
All right, so if you have a question for any of our panelists or for Lamont Scales from CDC, please type your question into the chat box and we will put you into queue and unmute your line. All right, we have a question for Jennifer. Can you share more about rights-based approach? What a rights-based approach looks like for shaping urban health agenda? Sorry about that. I'll read that one more time. Jennifer, can you share a bit more about what a rights-based approach looks like for shaping the urban health agenda?
Sure. Can you hear me?
Your line is open.
Can you hear me?
Yes.
Jennifer, go ahead. Be sure to unmute yourself.
Can you hear me now?
Yes, we can hear you. Go ahead.
Okay. So a rights-based approach simply means that young people have the right to this information, sexuality and reproductive health information, that they deserve this information, and they have the right to make decisions as it affects their bodies.
No, not right now. Okay, thank you, Jennifer. If you have any other questions, please type them into the chat box and we will open your line. All right, a question for Devin. All right, for an agency seeking to actively lobby, what initial steps should they take to move in that direction?
Okay. So one, I would always encourage you to check your local laws. As far as some jurisdictions require that you, if you're engaging in any type of lobbying work, that you register to lobby. And usually the agency at the state level that's responsible for that is the equivalent of whatever your state ethics commission is, and usually that sits in the same office as the elections office at the state level. So sometimes it's the Secretary of State's office. Sometimes I know in Georgia, for example, it's the Georgia Office of transparency and government accountability. So look for whatever the agency equivalent is in your jurisdiction to make sure that you do or do not have to register. But then also, I think the first thing to ask yourself is, are you lobbying or are you engaging in advocacy? Lobbying is to lobby on a specific, is to push a specific piece of legislation. So we're in support of House Bill 1224, right? That's lobbying. But advocacy, which is generally just saying, pushing, supporting general policy. So we're in support of more HIV, or we're in support of the PrEP drug assistance program, or we're in support of more public-private partnerships for housing for opportunities for people living with HIV. That's just advocacy, and you don't have to register to do that. So one, ask, what are you going to be lobbying, or are you going to be engaging in advocacy, because there are differences between the two. Another example of advocacy versus policy, advocacy versus lobbying is educating folks. Oh, okay. I hope. Educating people about general what's happening on the ground as it pertains to HIV. So holding, a hearing or something like that with local elected officials, just to educate them about what is happening in your communities as it pertains to HIV. That is not lobbying. That's advocacy. So a lot of your organizations, I think, to start off, probably won't be engaging in any direct lobbying, unless something comes up or you're familiar with the specific legislative proposals that exist in your community. Much of your work initially is going to be engaging in advocacy, which does not, anybody can do that. For answering Paul's question. And Marcus asked, as we have events such as Age Walk in DC, what the message? So I did. Mm-hmm.
Did you unmute me? Okay, so let's try this again. Thanks, Devin, for answering Ashe Hall's question. And we have another question from you coming in from Marcus McPherson. As we have events such as AIDS Watch in DC, what messaging should we use to encourage more people living with HIV, especially young people, to engage their elected officials?
I think you all should be frank. The fact of the matter is that it's not overly political to state the facts. The fact of the matter is that we have a president who has proposed some of the most drastic cuts to HIV prevention dollars domestically and globally. We have a president that is not in support of healthcare programs that are vital to helping us end the epidemic and keep people who are living with HIV alive and living happy and thriving lives. So I think being honest with people and giving them the facts. But one of the things that I didn't get to in my remarks was that while AIDS Watch is important, federal advocacy is very important, what oftentimes is not happening is that state and local advocacy. So coming to Washington, D.C. to lobby your elected officials, I would also hope that you would have gone down the street to City Hall or the county commission office or your state legislature to do the same. The other thing is, I think ahead of the 2018 elections, and it's okay, you can say elections. I don't know if the CDC folks can say that, but POs and other organizations can say elections. Before the 2018 elections, it is an imperative that you do engage in some voter engagement, voter mobilization. So what does it look like? Oftentimes, it's not very difficult to register people to vote, right? So that's step one. So registering people to vote, I think if you're having an AIDS walk or a walk to end HIV in your jurisdiction and you aren't registering people to vote, that's a missed opportunity. The other thing is also educating people about when elections are. So we know that there's the election in November, but there are a host of other elections that have implications for their health care before the November general elections, before the presidential elections. So educating people, sending out a reminder, a simple reminder, there's an election coming up and here are some of the issues that you should be concerned about. And the other thing is Nothing is stopping CBOs, and for the government folks, it's very different, but nothing is stopping CBOs from doing a candidate's questionnaire. There's a very different between endorsing a candidate. No 501c3 organization can do that, but you can ask candidates very direct questions and provide those responses to your clients so that they can make educated decisions as it pertains to how they're going to engage in the elections coming up this year and beyond.
Okay, thanks, Devin, for answering that question. Says check out www.afj.org, and the other, wow, has a much longer address, so hopefully you can see that information. And then here's a question that's come in from Crystal Townsend in Houston, and it's specifically for Lamont Scales. Lamont, Crystal is saying, can you talk a little bit about how the CDC is capturing data from the transgender community to better identify the risk of transmission of HIV? That question is for Lamont Scales.
Sure, and thank you so much for your question. For our health departments, we talked about surveillance a few years back. We provided guidance for state health departments on how to collect gender identity information. So that's a two-step process. We ask the question.
Lamont, we can't hear you. Can you make sure you're unmuted on your side?
Let's see. So it says I'm unmuted. Marcus says he can hear me pretty fine. Okay, so I won't touch the volume if you all can hear me. Great. So a few years ago, I think back in 2012 or 2013, CDC provided a guidance document to state health departments for their surveillance on how to capture gender identity information. So the first question was, what is your gender assigned at birth? And then how do you identify now? So that state health departments have been able to collect gender identity for transgender individuals for a very long time. Also through our HIV testing programs, we have a box for you to check for gender identity as well. So you will be able to see a number of health departments run their own reports, so you can look at who they're testing and who is testing positive within their jurisdictions.
Is taking destigmatization drug users more seriously. They are starting to adopt integrated programming and guidance based on targeting of populations, which is great. This is how we will succeed in addressing disparities. Thank you, Jose. And next we have a question from Orlando. It says, Sean mentioned PTNs and the need for evidence-based implementation. And this question is for Sean. Is there a resource page to see these proposed evidence-based implementations? Are there announcements and opportunities?
Hi, thank you for the question. So the HIV Prevention Trials Network, that is a kind of a worldwide kind of collaborative of clinical trials networks. And so they have a website, hptn.org, which you can go on to, and you can look at all of their research studies, both current research studies, past research studies, and studies that will be coming up. A lot of those are also done in the U.S. in collaboration with the National Institutes of Health, and so those announcements kind of go out generally in research circles. And in some cases, I think once we have like a full evidence base, you can also find some kind of interventions that are ready to kind of go out into the real world on the CDC's website for their kind of intervention research. So those are places to look. But I think as a general matter, the question is very important because I think we need to do a better job of bridging, kind of what's happening in the kind of the research space in these clinical trials, and connecting them to the community, so the community knows the studies that are coming into development. And once we have research findings, we kind of disseminate that research, not just among kind of academic or policy, experts, but to the community, so they can kind of know what that means and kind of develop a plan for actually starting to scale that up. And I don't think that's happening enough or effectively. And so I think it's a very important question. But yeah, there are a variety of sources. I'd first direct you to the HPTN.org website to get more information about the different research studies that I mentioned, the particular HPTN 073 that I mentioned.
Thank you, Sean, for answering that question. Let's see. Jose just chimed in and let me know that comment that I attributed to him was actually a comment made by Paul Harkin, who is a community rep for UCHAPS from San Francisco. And I should have known that was Paul's comment. Should have known it. Thanks, Paul. Are there any other questions that you as an audience want to pose to one of our three presenters on today, Sean, Devin, or Jennifer? Okay. So we're unmuting the folks.
Tune in to Channel 23 in unincorporated Fulton County and Channel 18 in the city of Atlanta for your very own Fulton Government Television channel. See firsthand your tax dollars at work with TV programs and public meetings all about Fulton County government services, programs, and events. You can also watch FGTV online by clicking on the county's website. Again, that's www.fultoncountyga.gov. Thanks for calling Fulton County Government. Someone will be right with you. Do you want to do business with a county? Details of the procurement process are just a click or phone call away. Learn everything from vendor registration to the bid opportunity.
Laughing now with that whatever.
Is it gone now? Is it gone now? Is it gone now?
No. It's gone now. You muted the right person.
So what did you think?
Okay.
Okay, if there are no questions, we will give it one more second and then move on.
Yeah, it's too freaking much going on.
Hi, everyone. We're going to take a 5-minute break while we separate our rooms. So 5-minute break.